Hi there, everybody. Looks like lots of you have joined us online. I hope you can hear me okay. Like to welcome you to the second of our webinar series, and today we're going to spend the next hour talking about laryngeal re-sensitisation. And you know, it's a frequently problematic area for us all, so we look forward to learning together about that area. Can I have the next slide, please, Sarah? Just like to thank you so much for taking the time. There's a lot of us on the call, so it's looking at 94 participants so far, so that's really great. Thank you all for spending time of what we know is a really busy time for us all, so we appreciate you coming today. Just a few introductions before we start. I'm Gemma Jones, I'm the chair of the Tracheostomy SEN. And in my day job, I'm a clinical lead speech and language therapist for acute services and the clinical lead for critical care in Cardiff and Vale University Health Board. On our panel today, thank you, Sarah. Our panel today is made up of Sue, Annalisa and Helen, who are also members of our committee, and I really appreciate them being today and taking the time to help us with the webinar and to join in the Q&A session later on after Sarah's presentation. So thanks guys for helping us out. The format for today is similar to the last one. We've got Sarah Wallace, our amazing SEN colleague, who's a consultant speech and language therapist in Wythenshawe Hospital and the speech therapy lead for the National Tracheostomy Safety Project, to take us through laryngeal re-sensitisation. Following Sarah's presentation, we'll have a Q&A session. If I can remind you all that there's a Q&A section and there is also a chat section. If you could put any questions for us in the Q&A section, just so that we can make sure that we get all of the pertinent and important questions out of that, it will make our lives lots easier, please. And you can chat and use the chat function at any point as well. This event is being recorded. And will be available to catch up or watch again for people who can't join us, and it's available on our new YouTube channel, the link of which I've put in the presentation, but we'll also circulate around the link after the event when we've uploaded it, so it will be you will be able to watch it again. Just whilst I've got your attention and before we launch into Sarah's presentation, to highlight that the next webinar of our series is due to take place on Wednesday, the 22nd of January. And there we're going to be looking at nasal high flow, oxygen and swallowing. And Annalisa, our speech and language therapist, and Paul Tooze, my physio colleague in Cardiff, are going to be doing a double act on that. So it'll be a really useful talk on kind of how high flow may impact on swallow and what we're looking out for in that. So please register in advance for that. The time, just to give you heads up, may alter, but we will let you know if it does. But currently it's scheduled to take place at the same time as this one today. So just to give you kind of hot off the press info. The last thing from me before I hand over to Sarah is that we really value your feedback, and we've developed a really quick online tool to do this. Again, it's in the chat box as well, so you can click on it there after this talk, just to help us plan about what would be useful for future webinars and give us feedback of where we can improve and what you'd like to see in the future. So please take some time to do that. That would be fantastic. That leaves me with no further ado to hand you over to Sarah. Thanks ever so much, Sarah.
Thank you, Gem, and thanks for inviting me to talk to you all about this topic of laryngeal sensation and re-sensitization. But the more I dug into this, the more I kind of came to think about the hypersensitivity issues as well with these tracheostomy patients. So we're going to touch on that too. My background and specialism is critical care, so that obviously is some of the basis that I have brought to this discussing this topic, and this is what I'm going to talk about. So we'll have a recap of laryngeal innervation, and then I'm going to dive into some of the research around impairment and share that with you, so that we can think about what a bit more about what goes wrong, and then we'll discuss the consequences of an insensate larynx, and as I said, a little bit on hypersensitivity as well. And then talk about finally how we can work on sensory issues with our patients to improve them, rather than just waiting for things to get better. So, quick recap for you. We know that the superior laryngeal nerve branch of the vagus is the key nerve involved in sensation of the oropharynx and the larynx above the vocal cords. And most importantly, what it does is evoke a laryngeal closure response. And this maintains our swallowing integrity. So it's really critical. The recurrent laryngeal nerve carries the efferent motor fibers, but also sensation below the vocal cords. So let's look at that superior laryngeal nerve a little bit more. So this is a really, really interesting paper. I'm going to talk this through because it's quite a heavy text slide. But the afferent signals which arise from the superior laryngeal nerve receptor field are necessary for normal deglutition or swallowing, and they provide the feedback to the central neural circuits, that's in the brainstem and higher in the cortex, that facilitate laryngeal closure. And this paper, they actually created anesthetic blockade of the superior laryngeal nerve in healthy people. And what happened was those people felt that when that happened, they found it really hard to swallow. They got a sensation of things sticking in their throat, and that their throat felt large, something that we typically refer to as globus. And they actually aspirated, so actually lost their airway protection ability. So 43% penetrated, half of those then actually aspirated. These are healthy normals, remember. So that's a really good study for demonstrating that nerve's responsibility for closing the larynx. When we talk about swallowing, though, we need to touch on the fact that the glossopharyngeal nerve also has a part to play in the sensory signals from posterior third of the tongue, palate, epiglottis, oropharynx, and this is really for initiation of reflexive swallow. So this paper, if you want to read a bit more about sensory input pathways, this paper actually reviewed 20 years worth of research in this area. Catriona Steele, who's from Canada, has done a really good job in this paper. So I'm just signposting that to you. So I guess this is the way I see sensory continuum. To me, it is a continuum in tracheostomy patients. We have some patients who veer towards the hypersensitivity side of things. And how this manifests is in problems such as inducible laryngeal obstruction, what we used to call vocal cord dysfunction, chronic cough, laryngospasm, which we often see in motor neuron disease patients, for example, the irritable larynx. And this is particularly a problem in patients post upper respiratory tract infection. Towards the other end of the scale, towards the hyposensitivity scale, in fact, I think this is more typical of a critical care tracheostomy patient, that they tend to have lost their sensation. And as a result of that, they have swallow down regulation, and then we run into all these problems associated with that, such as aspiration. And what we really want is to be somewhere just about in the middle, what I've just called the just right spot. So I suppose when we're trying to address sensation issues, we need to work out where our patient is on that continuum, and then work out what we need to do to shift them more towards the middle, perhaps. Easier said than done. So let's look at the sensory response a little bit more. So we know that if you stimulate the laryngopharyngeal mucosa, typically what happens is you get firing bilaterally of the thyroarytenoid muscles, and what they do is they close the vocal folds, the vocal cords, to protect the airway. This is referred to as the laryngeal adductor reflex, the LAR. I'm going to call it from now on, if that's a bit easier for me. And we also know, as many things with age, this actually is reduced. The response becomes weaker. So again, another really, really good paper by Doma et al. Around this whole sensory innervation. So what happens when you have a tracheostomy then? Well, the biggest thing is that the input to the sensory system, which is needed in order to then elicit your functional motor response, is affected when airflow through the upper airway is bypassed. And we know that happens the minute that you have an inflated cuff. And if you bypass the glottis, the supraglottis, and the subglottis, the whole tract, then this is likely to compromise that adductor response. So there are other causes though. It's not just about inflated cuffs. So if you look at my diagram here, you can see that we've got cuff inflation as an issue here. Airflow isn't stimulating the mucosa, but there are other problems as well. So intubation, we know, can cause mucosal alterations from friction, from trauma, and from damage to the receptor field. Patients may also have neurological comorbidities and damage to the nerves. So we talked about the importance of the vagus nerve and the glossopharyngeal nerve. That can obviously occur with things like stroke, Guillain-Barré syndrome, Parkinson's. And then the other factors to think about are more direct injury as well. Like, so for instance, if a patient's had cardiothoracic surgery and damage to the nerve, or head and neck surgery and damage to the actual structures or the nerve, or resection of the nerve. In addition to that, we know that reflux affects the mucosa and actually increases the sensory threshold, which means they become more hyposensitive. And edema and radiotherapy also do the same thing. So there's lots of things that could be going on in your patient that are contributing to a sensory loss. And I think one of our roles as speech and language therapists is to really try to understand what might be going on with your patient. And very often it is multiple factors, but if we can address the potential causes and weigh up the sort of relative contribution, which is really hard, then it gives us a clue what we might do to try to treat a sensory problem. So I'm going to look at each of those factors a little bit more closely. So if we think about intubation, we know that intubation trauma is really common. We're learning more and more about this as we go along. Martin Brodsky's done a lot of work in this area, so he reported incidence up to 83%. The sorts of symptoms that occur commonly with intubation trauma are voice problems, swallowing problems, and vocal cord pathologies, which we often see when we do a FEES. You know, we'll see problems with granulomas and problems with the mucosal trauma. And there are certain things that give you a higher risk of having an intubation trauma. We know from a fairly hefty amount of research now that the more tubes you have, the longer you're intubated, whether your intubation was emergency, traumatic versus planned, all increase your risk. And I dare I say it, I think COVID is another risk factor for increased trauma because of the damage to the actual larynx from COVID itself, as well as all the prolonged intubations. So lots of things going on around intubation that could be causing sensory loss. There are some warning signs that I think you can see sometimes in patients that you're going to have a sensory problem. So if your patient is awake, intubated, and tube tolerant, you can be pretty certain that they've got a problem with sensation in their larynx if they can't feel a big plastic tube down there through the cords. if we hear voice problems and poor cough, we know there's something wrong in the larynx, at the cord level. And what's commonly seems to be a problem is this muscle freezing that occurs from intubation. And I've seen this numerous times on patients when you scope them, that the vocal cords are just literally stuck in a open position and they really struggle to even move. And I think you can surmise that there's probably sensory and motor problems happening. And if a patient's got pooled secretions and they're not reacting to those secretions, they're not trying to clear their throat or swallow, then you know they've got sensory loss. So these are all clues to what might be happening, which you can pick up really early, actually, and then you can start to plan what you might do. And just, you know, again, it's another thing for having early intervention. Neurologically, as we said, there are a few things that are key, but there are a few other pointers here for different conditions and neuropathies that can directly affect sensory laryngeal sensation. Sorry, I'm not going to go into this very much. It's not my specialist area. Certainly, Sue can talk more about neurological issues if anybody has anything they want to ask about that. But certainly, commonly things like critical illness, neuromyopathies, and alcoholic neuropathies could be also contributing to sensory impairments. And alongside intubation is obviously the sedation side. So the sedatives themselves we know from research, can actually cause directly problems with laryngeal reflexes. So it's important not to just think about with intubation that the tube, but also the effect of the sedatives. And different sedatives appear to do different things in terms of impacting the larynx and the pharyngeal weakness, and even the breath swallow timing and coordination. So with midazolam, for example, if a patient's more likely to inhale post-swallow, then they're much more likely to aspirate anything that might be sitting on the cords. So it's a much higher risk. Excuse me. So how do we detect a sensory deficit? So I think, to me, there's sort of two approaches here. You either directly assess it, or you observe signs. So how do you directly assess it? So there's a few different techniques that you will find written up in papers, not necessarily things that we use clinically on a day-to-day basis, but there are papers which use a technique which delivers a little puff of air to the cords, the feast technique. That equipment that you need is no longer manufactured, so it's not something that we use, and it never really took off in the UK. But there's some really good research which has helped us understand better about sensation. There are a couple of studies which use a wire probe attached to a nasendoscope, which measures sensory response, and of course EMG, which can be used to check integrity of the superior laryngeal nerve. But as I say, those are all a bit in the sort of research bubble. In real life, one technique which people tend to use is the touch technique. So if you're doing a FEES or any other kind of nasendoscopy, you can touch the tip of your scope directly to laryngeal mucosa, to the arytenoids, or to the cords themselves, and that should invoke the adductor response, the LAR. However, one thing to say about that is you could cause laryngospasm, so it's not something that people, I'm not recommending you do it. It's also really unreliable and diagnostically could be quite inaccurate. And the reason for that is that when you touch, you are not applying the same pressure every time you do that in the same patient or even across different patients. It's extremely inaccurate method, but it might be something you accidentally do, I suppose, if you have a scope down and a patient suddenly swallows and their larynx raises to the scope that you actually might touch. Now, ideally, you shouldn't be doing that, but it is something you will see in papers. Alternatively, you can just observe signs, and this is something as dysphagia therapists that we understand really well. We know that if patients don't respond to a wet, gurgly voice and they're just talking through their swimming pool of secretions, that there's a problem with sensation. Same if you let the cuff down and there's no coughing, there's no reaction. And if you're using a FEES, for example, and you see a lot of residue in the pharynx, or you see the patient aspirate or penetrate and they don't do anything, and they don't even feel the scope in their pharynx, then you know that there's a sensory impairment. You can't quantify it though, and that's what the other techniques have tried to do. I suppose the best that we get to say is that there is, sometimes a patient appears to be completely desensate, as opposed to having, you know, a slightly impaired response, but it's really hard to quantify. So what does it mean if your patient has an absent laryngeal adductor reflex? Well, those three papers that I've just scrolled through all talk about the impact of that in a tracheostomy patient in particular, but because of that lack of closure, it increases your risk of penetration, aspiration, and of things sitting, food and drink sitting in your pharynx post-swallow, and you're not doing anything about that. And in fact, the papers that looked at dysphagia patients as opposed to healthy normals showed a 6.8 times, they were 6.8 times more likely to actually develop pneumonia. So that is a really functional, clinically important consequence, isn't it? That if that is the case. And again, just to bring it back to intubation, this paper looked at patients who'd been extubated and found an absent LAR in 50%. 50, that's a lot of patients. And again, it correlated with a severe dysphagia. So more secretions, more diet restrictions, and more aspiration seen. So really, really clinically important consequences of this. So speaking of consequences, I've tried to summarize them here in this sort of table. So if you have a sensory impairment, you have lack of movement as a result of that. So inertia will then lead to more problems with weakness, more disuse atrophy, more problems with voice and swallow. And again, if you've got aspiration, it's going to be silent. And we know that the patients who silently aspirate have a much worse outcome in terms of morbidity and mortality. And if you're not reacting to your secretions and you're not able to clear your secretions, you're more likely to have trouble weaning with your tracheostomy, tolerating cuff deflation, even decannulation itself, and more likely to get an aspiration pneumonia. And if you've got a more severe problem with your swallow, you're more likely to be nowhere mouth for longer. And we know that that has huge psychological detriment to our patients. So anything that we can do to speed up recovery of laryngeal sensation will help, won't it? So how do we do that? I've tried to summarize this in terms of three approaches, I suppose. So firstly, restoring airflow. As we said at the start, we know that airflow is important for that mucosal receptor field to sort of stimulate that. So there's different techniques we can use for that, which I'll talk about in next. We can actually directly potentially stimulate, again, using different techniques, tastes, pharyngeal stimulation. Or we can do other interventions which sort of more indirectly impact on sensation. So pharmacological management of things like edema and reflux. And also some papers I found talked about neural anastomosis, where they actually tried to actually re-innovate an impaired superior laryngeal nerve. I'm not going to go into that because I don't know how, it's not a very common thing to do, and I'm going to focus on the things that we're more likely to need to do day to day. So restoring airflow. So right at the beginning, one of the ways to do this obviously is above cuff vocalization, which we can use the subglottic pore to introduce a retrograde gas flow, which restores that airflow through the larynx without needing to deflate the cuff, if you can't deflate the cuff right at the beginning for any reason. And sometimes that is the case, isn't it? I mean, getting the cuff down early is critical, but sometimes you might struggle to establish that. So ACV, we know that from some papers that it does have an impact. This paper looked at patients who were low arousal brain injury patients, and they saw more swallowing activity and fewer secretions as a result of doing this technique. My own research with Brendan McGrath and the team here, we've seen some interesting things as well. I mean, you know, it's a very at the moment it's not a very refined technique, is it? And there is lots of safety concerns with ACV, but what we've seen, I think, in our last piece of research was some real benefits to secretion ratings, which is this one here, aspiration scores, and just more swallowing and more coughing when you turn on the ACV flow. So by measuring those things, I was able to sort of pick up the other effects on laryngeal sensation, and we're looking into that also further on our current research project. But just to show you that, apologies if this is a little bit jerky, but you can see here that situation where I said the vocal cords are just sort of inert. They're not really opening or closing, and there's just passive aspiration. And then we're turning on the EACV airflow, which clears the secretions, and I think you can see some movement of the cord on this side. There's obviously a palsy issue over here, but at least there was some movement occurring as a result of that airflow, and that was a sort of instantaneous response. Second thing, though, is obviously to get the cuff down and to use one-way valve, passenger valve if you're a ventilated patient. Cuff deflation alone has less of an impact on aspiration than if you use the one-way valve as well. You'll have much more reduction in aspiration risk with the one-way valve because of the things that it does around restoring subglottic pressure, as well as all the other benefits that Annalisa has studied in a lot of detail and can talk about there much more than I can. So it improves laryngeal clearance. Sometimes we see, don't we, that patients don't seem to tolerate cuff deflation or the valve very well, and actually what they do is they cough and cough and cough, and it's uncontrolled coughing. That's where I see those people who are on the kind of hypersensitive end of the continuum, and what you need to do there is slightly different. You need to get them used to that airflow again by gradual partial cuff deflation trials and passing your valve trials. So that's a sort of, they need a different approach. In terms of stimulation, one of the techniques that we commonly use, don't we, a therapeutic TACE, and I think generally it's in patients who are quite risky. So, you know, if you have fees or video fluoroscopy to guide you, it's probably much safer. And what I would suggest is that if you use a very structured, methodical approach, you're much more likely to be able to monitor that there are no detrimental effects of somebody having tastes. It's good to give as much sensory stimulation as possible. So, you know, we've got research from years ago that talk about using cold boluses, sour boluses that give you a heightened sensory input. But obviously one thing I would say in a critical care population is that we would probably avoid doing tastes with a patient if they were during the day. I mean, if they were particularly fatigued, or if they were on a weaning challenge, or if they were unwell with sepsis, for instance, or a VAP, because it's just an additional extra layer of difficulty. And if their swallow is fragile, those things will potentially tip their swallow over the edge, and they're more likely to aspirate. So what is crucial is a real MDT approach to this, an agreement from everyone that you're going to do taste, you're going to monitor them carefully, and you know, physio is vital for that, in helping us to understand that we're not causing any harm to the chest from aspirations. Another technique obviously is pharyngeal electrical stimulation, and this is not something that everybody's using obviously, but it is something that we're hearing more and more about. We've been using it with Ensure for a while now, and for those of you who don't know, this is a modified NG tube catheter, if you like, that has metal around it that stimulates intraluminally in the pharynx directly once it's attached to the box there on the left, this base station. And it's come from research on stroke patients, and they've demonstrated that it induces some reorganization in the cortex of the swallow response. So the research has focused on stroke patients mainly with tracheostomies, but the FADA study also looked at other patients who were tracheostomized and ventilated in ICU. And overall, that they demonstrate that it's a safe technique, it improves dysphagia severity, and it actually facilitates decannulation earlier. And in the patients that we've used it with in Ensure, we're also getting similar very positive vibes, I suppose, positive outcomes. We're measuring it very carefully, pre-fees, pre and post treatments, and seeing that patients are returning to oral intake sooner. I'm just going to show you one of our patients pre-treatment and then one post. So you can see here, this is a fairly awful swallow. This patient's had a bolus of milk, and they're just passively, it's sitting in the larynx, they're not responding to it particularly well, and they're aspirating at rest. So this patient then had 6 10-minute treatments, 10-minute treatments for 6 days running, and then a post-PES fees. So this is the post-PES fees images, and you can see immediately the larynx is clear. I can assure you I haven't doctored these images to make it look good. This is exactly what we saw, a much improved swallow, basically, less residue, less aspiration. So yeah, that's a promising treatment, definitely. Pharmacologically, we can use treatments, I think, to sometimes improve sensation more indirectly. So if we reduce saliva burden, we can get the cuff deflated sooner, which allows us to restore airflow and wean the patient. For patients with laryngeal edema, sometimes it's appropriate to use a steroid like dexamethasone or budesonide or something like that, with discussion with the MDT, obviously, in the medical team, because if you reduce the edema, you can improve sensation. And obviously reflux is something that should be looked at closely. It's common, it seems to be common in tracheostomized patients, particularly in ICU, and does cause sensory deficits. So if you're feesing, you can use things like the reflux finding score to quantify the severity of the reflux, and that helps you understand whether you need to treat it with a PPI or not. If you're not doing fees, you can ask patients to do the reflux symptom index, which is a questionnaire really, which helps to highlight signs and symptoms of reflux. But there are risks of using PPIs, as we know, so it's not something you should just give to all patients. This image here was a patient of ours fairly recently who had a massive granuloma there, which actually was flopping about in the airway and obstructing the airway from chronic reflux, which actually needed surgery. But yeah, it's definitely something we should be on the lookout for as a cause of sensory problems, and we can treat it. On the other hand, we can teach the patient some strategies as well in order to compensate for sensory loss. So we can actually get a patient to try to listen to their own wet voice, and then teach them to do purposeful swallows and throat clearing to increase their awareness and understanding of the need to swallow and the need to throat clear. And if we have FEES images showing them that obviously helps them to help the education side of it and the biofeedback side of it. So they're much more likely to be able to learn to do that strategy. Same with EMG, surface EMG, we can use that in order to show them what happens when they do a swallow and the effort required. So the other thing I'd say is that if you are using airflow techniques like ACV or cuff deflation and passive-mure, that if you do dysphagia exercises during the airflow techniques, it really optimizes the stimulation and the motor response. Because they're having some stimulation, if you kind of just making the most of it, because they've got maximum stimulation at the time that they're doing their exercises. So doing them together, I think, works best. Just a note about hypersensitivity. So as I said, if you've got a problem that you think is more towards this end of the scale, you will have to address it by gradually introducing airflow tolerance. So low ACV flows, partial cuff deflations, and gradually increase durations of cuff down and PMV. And for some patients that can be really, really difficult and take quite a long time. So the other thing is that you can use images. If the patient's reporting sensations like globus, or they think things are sticking in their throat when they're eating, if you're trying to establish them on oral intake, you can use the FEES and VF images to reassure them there isn't anything actually there. It doesn't change the fact that they're feeling like a globus sensation, but it does help them to not be so fearful about it, and you can re-educate them about it. And then some patients are going to need much more investigation by our colleagues with expertise in voice and voice clinic to use strategies to deconstrict, or go to cough clinic or airways clinics as well if we have a real problem with this, which again is not my area of expertise, and is probably a whole other talk. So finally, I suppose, just to round it all up, I think hypo and hypersensitivity to me in trachea patients is a sort of continuum, and we're trying to bring them patients from the edges of that to more towards the middle in terms of our treatment. And restoring airflow however you can, as soon as you can, is probably what I would recommend. I don't know if the others agree. And remember, your sensory stimulus is most effective if it's done if it's dynamic, and if you're doing exercises at the same time. There's a lot we still don't know, and I think in order for us to really help our patients to get back onto oral intake quicker, this is Richard looking very happy with his toast and marmalade. You know, we can't just wait for sensory issues to resolve. We have to actively diagnose those problems, work out what's going wrong, and treat them in order to actually improve the motor aspect of their swallow and their voice, instead of the focus being on, well, what exercises are you going to give your patient? Think about, well, what are we going to do to re-sensitise and address that issue? So yeah, I think that's enough from me. So thank you for that. Thank you for listening. I'll refer you back to the panel now for Q&A.
Amazing. Thanks so much, Sarah, for that extremely knowledgeable talk about the larynx and its complexities and the impact it has on our patients, and a kind of understanding of why it is so tricky to get that continuum and get that right spot right for our patients. I know, looking at the Q&A, we've got a large amount of questions come in, so thanks ever so much for those. I'll hand you over to Helen now, who will take us through some of the key ones. As I said before, it might be that we can't answer them all, but we have got a record, and we will look at them as a committee with Sarah and try and get them the main ones answered for you. Thank you, Helen.
Thank you very much, and thank you very much, Sarah. There are a lot of really good questions. So picking one of the first ones, just a question about the diabetes. In the talk, you mentioned that a diagnosis of diabetes might increase the risk of intubation trauma. So any of the panel able to explain just a bit about what diabetes does and why it might increase the damage?
I can kick off and just say that I know very little about the specific laryngeal injury damage that has been reported and why, but I know that diabetic patients are sicker, and there is definitely reports that they are ventilated for longer. So I think there's a definite link there with duration of intubation and predisposition to laryngeal injury as a result. I don't know if anyone else has got anything else to add.
I think the other aspect is around obesity as well. So the link to having higher BMI, therefore being potentially more difficult to intubate. So increasing your risk of trauma as well as those things you mentioned, Sue. Yeah.
Yeah, and vascular issues, yes. Peripheral vascular changes in diabetes and tissue healing in general. Someone's asked about cough reflex testing for checking sensation. Thought that was a nice, interesting question.
So I'm just, I'm very aware that I think it was Trimble and Patterson in 2020 produced a consensus. Well, they did a kind of looking at the statement, the kind of state of play with regard to reflex testing and its use, uptake by speech and language therapists. The problem is it's really just a technique that's used clinically in stroke. And what they found is that we're really lacking a consensus statement on that in terms of its use and applicability. And certainly the questions about its applicability to recently intubated or trachea patients, I'm not aware of any research on that at all.
Okay. So no research as we know it in this caseload. Okay.
Yeah, it's not been validated, has it, in this population at all? It's not at present.
There are quite a few questions about starting some of these techniques in a place where they don't have clinicians with experience of various techniques. So starting with ACV, any advice on starting ACV in a trust where none of the MDT have experience in it?
I feel that one's for you, Sarah.
I was happy to keep quiet and let other people answer the question.
It's definitely your question.
I think, the ACV isn't a complicated thing to do. I think the key is to have a team approach though. And I think what is crucial, I suppose we've had to be brief about it, is that speech therapists are involved in the initial assessment of ACV. Because one of the risks obviously is that you don't have a patent upper airway because you've got either bilateral cord problem or edema, and then you've got a blockage, and then you risk the airflow not escaping up and out, but to the soft tissues. So that's what we call subcutaneous emphysema, and that's really dangerous. And part of, I think one of the things ACV allows us to do is the sort of things that we do when we do the first cuff deflation, but earlier. So the things we're looking for in terms of laryngeal function, we can gauge to some degree. If you do an ACV trial and you get airflow, you can hear secretions, you can hear what happens if the patient tries to vocalize. So I think it's really beneficial. It's also a way, I think, for us to bring together an improvement in joint working and bringing the speech therapist in earlier into an ICU where perhaps historically you've had less ability to be part of the team, and I think there's just what we're lacking is clear guidance and protocols. I've got a protocol I'm happy to share. As I say, I'm doing quite a big hefty piece of research at the moment around ACV airflow, but more about the technique, but also what it does, measuring the sensory response. So there's a lot we still need to understand. But I think it's a really good way for speech therapists to get involved early. But what you don't want is everybody going off doing it willy-nilly without being aware of those risks. Does anyone else want to say anything?
I was just going to say that I think that's a brilliant idea, Sarah, that it's a really good way into ICU perhaps, because cuff deflation and the impacts of cuff deflation on the intensivist minds quite often are quite confronting, I guess, and it's really hard for a speech and language therapist to go and argue their case again, I guess, as to why we should deflate someone's cuff that is still ventilated. But by being able to actually provide them with a lot more information about their patient and not deflating the cuff, and also giving the patient the chance to get that recovery on the way, then that's a fantastic way, I think.
So on the same topic, there's been a request for more information on the specifics of protocols. So are there standard protocols regarding the amount of time and what pressures to use? And I think at this point it'd be worth just referring people to Sarah and Brendan's paper on the risk assessments that you need to be doing if you're thinking of doing ACV. I can't remember the title of your paper, Sarah.
It's on the slide, but also there's stuff on the NTSP website, but also I'm happy to share my protocol by emailing it out. There isn't a standard protocol. It's just what we've pulled together.
But we can email that round through the TracheoSend email list. Great, lovely. And the other technique that people are really interested in is pharyngeal electrical stimulation. Someone's asked, is it safe to be used, or is it being used outside of research trials?
Yeah, it's not a research. It's not bound by the RCSLT guidance on electrical stimulation techniques. It's allowed to be used on patients. It's not an experimental treatment. It's well established, based on 20 years research by Professor Shaheen Hamdi. So it's licensed. It's equipment you can purchase and you can use. So yeah, does that answer the question? Yes,
is training available? Was one of the questions, and there was a question someone was asking about who actually delivers it. So who places the tube and then who delivers the actual PES treatment? Is it medics, nurses, SLTs? How does it work?
So I can tell you what we do. We actually get our nutrition specialist nurse to pass the special NG catheter. It looks slightly different from a normal NG, so she's been trained by the company to pass the tube. In terms of delivery of the treatment, that's done by us, our team. I suppose other people could be trained to do it. It's actually really easy to deliver the treatment. You just plug it in and press a few buttons. But what we are obviously, what I'm keen for my team to do is obviously be quite robust about collecting the data, the outcome data. So we are doing feeds pre and post, or you could do video fluoroscopy pre and post. It doesn't really matter. But I think if you're just reporting your outcomes as, I think this one was better, without an instrumental evaluation, it's not very convincing, is it? So I don't know if other people have used it. Sue, have you ever used it? You were in part of the study, weren't you? Fast track study.
No, I've not used it clinically. We're hoping to start it here with some of my colleagues. I'm looking at it in the neuromedical and neurosurgical cases, but I've not used it, so I'm hopeless to answer this.
But the it's very easy to do, and it's literally 10 minutes. I think the issue is we're working out what exclusion criteria are best for using it on a critical care or trachea patient, and that I've put together a few things that have come from my learning, I suppose, and the learning of my team around what, you know, for instance, if a patient's really cognitively impaired, I don't think they're going to be able to cooperate very well with the treatment. If they're delirious, I wouldn't do it. There are some key things that are exclusion criteria, such as the patient can't have an implantable electrical device, such as a pacemaker, because it's got metal on the tube. So, you know, you're going to deliver electrical stimulation. They can't be needing to go for an MRI scan, because obviously metal again. So those are the only actual real exclusions. Everything else is just coming from sort of clinical intuition, I suppose, on what we've seen. So we need a patient to be understanding what the treatment is, able to cooperate, so that when you turn up thresholds, they will be, you know, on board with you trying to give them the maximum treatment. So yeah.
Sarah, are your patients quite severe, the ones that you choose for PES treatment? Are they quite severe dysphagia? Because I think there's some literature out there that it hasn't worked as well for patients that were not as severe with their dysphagia. But...
Okay, ours are, yeah, they're all really profoundly dysphagic. But with it, to me, it's got to be primarily a big sensory impairment issue. Yeah.
Thank you.
And they're not so, I mean, they're stable as well. So hemodynamically stable patient, not someone who's really, you know, currently poorly or got sepsis. I think you're more likely to, we have occasionally seen a little bit of an, you know, edema on the post-PES fees, and wondered if the patient had got an inflammatory response going on, and then we delivered the treatment. But when I've talked to the company are brilliant at providing any kind of support or training that you need. You know, that's where you get your training from, is they will come in and they will help you in every way, shape or form. They're very supportive. But I think I'm veering away from using it on a patient who's got any kind of active sepsis. Obviously, they'll be a little bit more confused anyway. So I think those are the things that we're learning.
Okay, we've got a question from physiotherapy. So the question is about what physiotherapists can do to help support SLT teams in progressing the tracheostomy wean with techniques that might be able to be done by non-specialist staff. I think the question is sort of SLT type rehab that could be delivered by the MDT. Anybody, any thoughts?
I think we've had quite a lot of support from kind of rehab techs that have been, you know, we've set up the program for swallow therapy or those kind of things, and the techs have helped us carry it out to, you know, to kind of maximize the impact of that. And I suppose, you know, just general team working, isn't it? The MDT, we all work better and get better results if we all work together on these things. So with regards to supporting anything like ACV or cuff deflation trials and PMV trials, that, you know, if we work together, we're far more effective. So it's just kind of linking in and supporting each other through the process, because ultimately there's so much crossover in our roles with regards to particularly around tracheostomy weaning. And those discussions as well about secretion management, and whether, like our last webinar, you know, what is the kind of balance between those respiratory and pulmonary secretions, and how do we kind of maximize it so that the patients get the best results. And I think those discussions are obviously far better had as an MDT. We don't work very well in isolation in critical care at all. So yeah, I don't know whether that answers the question really, but we're obviously key, aren't we, all of us, to this, to progressing patients through these problems.
Yeah, I think and just having an awareness of what your physio or SLT colleagues are doing in their rehab, and you can incorporate that when you're doing yours. So the whole secretion clearance, getting good head and neck alignment when people are swallowing, things like that, that are kind of can be transdisciplinary. Focusing on catching both goals at the same time.
Yeah, absolutely.
There's a question about, is edema in the laryngeal area associated with hypo or hypersensitivity? Or perhaps both? So specifically edema related issues.
So I think it might depend on the underlying cause, and it's really hard to establish that sometimes, because I know I read a paper once that said there's potentially 30 different causes of laryngeal edema in a critical care patient. Edema related to reflux is definitely associated with hyposensitivity, so you have impaired sensation. Edema which is related to an overall inflammatory response. You know, the patient might be edematous everywhere, but they might have congestive heart failure. Again, I don't know. I'm assuming it's generally always a loss of sensation. Does anyone else know?
I don't know, but I tend to agree.
Yeah, me too.
It's usually whenever we see on fees that they're quite edematous, that it's usually associated with reduced sensation in the area, I would say.
Agreed.
But again, I haven't seen the clear evidence on it that all causes of edema would be causing that.
It's a really good question though, and I'm not quite sure that we know the answer, because you do see some patients who are very hypersensitive, and when you fees them, you can see the abuse going on through the constant coughing or constant clamping down on maybe their false cords to try and protect themselves from what they perceive as aspiration, and that itself is either contributing to or causing the edema. So I think the jury's out.
And I think edema is sometimes just because of the irritation created by the pooled secretions as well. So I think you're right. It could be that they're hypersensitive as well, or yeah. I think trying to get at the cause is probably key, but also, yeah, this is what I'm saying. There's a lot we don't understand that we need to learn.
We've probably got time, Helen, for if there is a quick question just to finish up before we say.
I've got one because I'm very biased because it's my research area, but there's, what are the panel's thoughts on tube size selection? Is given what we've talked about today, and the tendency to cite larger tubes for safety, with the reluctance to discuss tube selection to facilitate things like ACV speaking valves and things. So
I think you need to answer that.
I was about to say that.
Yeah, I think
brief though, Helen.
Yeah, most SLTs and physios are probably quite keen to get the speaking valve on, or the one-way valve on, to help with speaking communication weaning. But then we've obviously got to think about, you need a competent cuff, so you need a certain size tube to make sure people can ventilate well. Anyone else got any thoughts?
Yeah, bigger is not always better.
Yeah, agreed. I reckon that we should leave it on that note. I think that's a perfect place to end. Thank you to everybody who's listening and attended today and engaged so well with the Q&A. There was a huge amount of questions that we've obviously not been able to get round them all, but we will take a note of them, and we will come up with a plan to kind of get protocols circulated and get some of those themes answered for you. Thanks to Sarah for your time, for your amazing presentation, and the panel for your time as well. I really appreciate it, and we'll hopefully see you again on the 27th of January. Hope you have a really happy, restful Christmas, and yeah, we'll see you in January. Thanks ever so much. Take care.
Okay, bye.
Bye.